See You Now is a podcast highlighting the innovative and human-centered solutions that nurses are coming up with to solve for today's most challenging healthcare problems. Created in collaboration with Johnson & Johnson and the American Nurses Association, and hosted by nurse economist and health tech specialist, Shauna Butler.
Welcome back to See You Now. I'm your host, Shauna Butler. We launched Season 2 during this wild moment we're experiencing with the coronavirus pandemic continuing to spread across the globe and throughout our communities. And right now, the ground is shaking for everybody, differently and to different degrees. But for the most part, the ongoing uncertainty is happening for all of us. There's big stuff happening, and there's a lot to say, discuss, and consider, and a lot that requires an innovator's attention. With that in mind, it's on to See You Now, Season 2.
We're always, every shift, every hour, trying to do better for our patients, do things in a more efficient way. But suddenly those skills were needed. So yeah, we were always innovating. It was just not visible.
I have to give it off to my colleagues in Mount Sinai, but as well throughout the world, nursing staff and hospitals, everybody. Essentially thank social media, because if it wasn't for that capability, we would all be lost.
COVID-19 has, as never before, piqued the media's interest and curiosity about nurses. While they're hungry for the drama of what nurses are seeing, what they're experiencing, and how they're coping, they're not always digging deeper to reveal the role of nurses as experts and innovators, of their unmatched feedback loops and the proximity to problems and suffering, and the urgent demand placed on them to deliver solutions now. We open Season 2 with an episode that shares some of the details that don't often appear in the headlines or make it in the stories. And when those details go missing, it can be hard to piece together how complex, how innovative, how human, and how all-encompassing the work of caring for people is. Simone Hannah-Clark and Carlos Chochez are two of the many thousands of nurses who work in intensive care units across the globe. They turn treatment plans into action. They question when things don't make sense and are unsafe. They find solutions that work. They stand between the patient and the enemy, and they innovate in real time. Thank you guys both for taking some time to talk with me about your experience in being some of the very first nurses to meet and make friends with our enemy, COVID-19, SARS-CoV-2. Carlos, can I start with you and ask you to introduce yourself?
Sure. My name is Carlos Chochez. I am a medical ICU nurse over at Mount Sinai Hospital on the Upper East Side of New York City. I've been working there for 2 years now, so relatively new. And yeah, we were one of the first units to disperse throughout the hospital once COVID hit. So we have a lot of, I guess you'd say, things to say, and a lot of, I don't know how to explain it. We're thinking that we're making progress, and in some ways we are, but we still don't understand this. It's going to take
a steep learning curve, a very
Exactly.
steep, yeah. Simone, could I get you to introduce yourself?
My name is Simone Hannah-Clark. As you can probably tell from my accent, I was born here. I grew up in New Zealand. Went to nursing school in New Zealand, worked briefly in New Zealand and Australia before coming to the United States. I've been a nurse for 15, going on 16 years now. I've been in critical care, specifically ICU, for the large majority of my career. And I'm passionate about, I like being with patients. That's why I became a nurse. I like the hands-on care. I'm passionate about getting nurses' voices more to the forefront of conversations. I feel like with COVID, it's been a huge opportunity for us to be more visible.
And what's your current position?
I'm a clinical nurse in the medical ICU at Mount Sinai. I'm one of Carlos's colleagues.
Can you describe Mount Sinai in terms of its specialties, the community that it cares for, what it does really well, maybe what it's even challenged by?
Mount Sinai is an academic teaching hospital. It's on the Upper East Side of Manhattan. It's quite unique in that it borders two neighborhoods, East Harlem and the Upper East Side, predominantly high socioeconomic area, and East Harlem has more racial and economic diversity. It's right near Central Park. We are a liver transplant center, so we get a lot of liver patients from all over. We have a huge cardiology department, cancer center. We do everything. We do everything there. And again, very diverse patient population because of the physical location of the hospital.
Yeah, Simone, so can you take us back to your recollections of end of January, early February, when most of the story about coronavirus and COVID-19, we're hearing about what's happening in China, Italy, and the warnings that so many of the nurses and doctors in Italy, the pleading that they are making with the rest of the world, showing us what they're seeing. What was that experience like for you?
It felt like it happened overnight to me. I mean, we were hearing the rumblings of this coronavirus, COVID-19, as they were calling it, a novel coronavirus. Rumblings of it. We were seeing what was happening in Italy. This isn't the first time we've been told a pandemic is coming. Mm-hmm. I mean, with the Ebola outbreak, Mount Sinai, we prepared for that. So it did feel similar to the beginnings of that, where we were sort of on alert, we were sort of planning, we had some of those other respiratory viruses. So it sort of felt like that. And I mean, honestly, I was like, oh, it's just going to be like that. We're going to sort of be on alert. We're going to try and prepare as best we can. And I have to say, I didn't really think it was going to turn into this. I really didn't. And then it was probably the last couple of weeks of February where it did feel like the temperature went up, and it felt like it was going to be upon us. And then first few weeks of March, we started to open up the first COVID ICU in one of our other units. And we were deployed there to manage the day-to-day operations of that unit. That was, I guess, mid-March, was it, Carlos? So it's sort of hard to keep track of it now, but I think it was mid-March. And it seriously, to me, when I look back, it felt like we were getting these patients. They tested negative, their PCR was negative, and then all of a sudden it was just like positive, and every room was filled with a patient who was positive. Mm-hmm. And then we went from we were full to the other units started converting over to COVID ICUs. And then literally one day, we were told you have to figure out how you're going to double your capacity. You have to figure out how you're going to put 2 patients in one room. It escalated incredibly quickly.
So that is a statement that's got a lot of questions that need to be answered. When someone says you need to double your capacity, yeah, the numbers of questions that come to mind, I feel like if it were me hearing that, I would feel like I was drinking from a fire hydrant.
Yeah. Yeah, 100%. It did. It felt like that. And, obviously as nurses, we are thinking 1 to 5 steps ahead, because we are the ones who have to figure out the logistics of this, and we're the ones who have to coordinate all of the patient care. So it really felt to us, it felt like, which, as it should, we're the experts in this case, but it really felt to us to figure this stuff out. And it was like from scratch, we're like, okay, so where's the bed coming from? What monitor are we putting these patients on? The monitors we have only have the capacity for 1 patient at a time. We need transport monitors. How are we going to transcribe the information from those monitors into our electronic records? do we have enough defibrillators? Do we have enough ventilators? And then in the same breath, we were looking at Italy. Like, this is when Italy was peaking, when we were just starting to. And we were like, oh my God, do we have enough ventilators? Like, how do you split a ventilator? Like, we're standing in these rooms asking these questions to each other. We don't have answers, but, we make it happen. Everybody the teamwork was incredibly inspiring.
You are confronted with a set of realities. You have to go from one state to another state. Mm-hmm. And it's all of the details in between. And so there are a set of questions that start coming to mind. To your point, where do we find the beds? Where do we find the ventilators? How are we going to manage the configuration? Are there enough electrical outlets?
Yeah, all of those things.
You get this demand. Basically, it's not that it's an executive demand being made. It is a care demand. They are just coming faster than you can possibly even imagine.
Nobody would choose to have that situation, right? Like, it was out of our hands. You have to do what you have to do.
Right.
And all that happened in one day. It felt like 5 years happened in that day. Carlos and I were both working that day, and we were told we have to double our rooms up, and we found an extra bed, and we had an empty room. We knew we were getting 2 admissions from another hospital in the next couple of hours. So they were going to be the first 2 patients we doubled up. We were working with a new team of people. We all had different ideas about how the room would set up. And I brought some of my other nursing colleagues in the room, and we all sort of nutted it out together. I took photos of it. We put these 2 beds in the room. We got a ventilator, got a transport monitor, and we configured the room. And we walked through it. We imagined ourselves doing CPR, intubating, cleaning the patient, just doing regular care to see if we could fit.
So rather than a whiteboard and spreadsheets, you guys were in a physical space choreographing the movement.
Yeah, that's the perfect description. We moved the pieces around and we figured it out in real time. And we knew, in an hour, we're going to have 2 patients in this room, so we need to figure this out.
Taking in everything that we learned from our first 2 patients and kind of making it better, perfecting the process, correct?
Right.
And until our MICU was doubled throughout every single room. Mm-hmm. Our 14-bed room became 22 patients, and we're like, wow, I guess we were able to do it.
Yeah, I mean, we didn't have any idea at that point that this was just going to be our norm for weeks. It just snowballed. Then we doubled up pretty much every single room, and then, right, Carlos, at that point, they have turned our home unit, the MICU, into, they put doors on it was an open unit. So they put doors and converted them all to negative pressure rooms. So that process happened in a day and a half. Once we sort of figured out logistically how to run that, the flagship unit, as it were, we went back to our home unit, and straight away we were doubling up patients in those rooms.
So rapid iteration in real time.
It was, oh my goodness.
All hands on deck. We would have real-time huddles, which we need to address this. This is very important. Such as the tubing outside and how we can improve our safety and the patient safety as well.
Yeah.
And after, I would say every morning and right before our shift ended with the oncoming team, we would just give them all this information. Today we did this, this, and this, and this would just carry on shift after shift after shift. At the same time, those who weren't able to be present because they weren't on shift that day or whatnot, they would get a message. We would send out messages so that everybody can be as informed.
Yeah, the communication was really on point.
Yeah,
we have a WhatsApp group for our nurses, and that was just blowing up. The phone was blowing up. We had message after message, and it was actually a really amazing way to stay informed. But as Carlos said, real time, huddle. We had this list. We had just a piece of paper, and on it, it was what do we need? And we would just write, we need this, this, this. And we couldn't help each other enough. The CEO and the CFO, they were very visible during that time. They came down, what do you need? How can we help you? I mean, it was really something. It did feel analogous to being on the front lines of a war. But we were incredibly lucky at our hospital that we had a lot of resources and we could mobilise those resources very quickly. The tubing situation where we had
describe the tubing situation, because we've heard and we've seen stories about that, but I'm not sure people really appreciate what original care would look like and what the transformation was like and why you needed to have this transformation.
I mean, I'll speak to what it normally looks like. Carlos is like our hack, like king at work. So I will let him speak to the hacking of the tubing. But normally, all your pumps, your medications are all in the room. Like critically ill patients often require continuous infusions of vasoactive medications, sedation. So those pumps are in the room, as close to the patient. And we're titrating those drugs every few minutes. So during COVID, that would involve donning and doffing extensive PPE each and every time we went in the room. So I don't know where the idea originally came from. It could have been Twitter. It was like our colleagues in Italy, in China, who had first devised this idea. But I think it may have been even that same day that we just started hacking our IV tubing. Carlos.
Just being on social media and just seeing what other nurses were doing. I remember even on my day off, I would just be on my social media and just looking to see like what else we can do to improve how we can administer medication or nutrition without getting our staff to don and doff all the time and potentially get them into more exposure of COVID, right? Yeah. And so I remember texting my managers like, hey, there's this idea, maybe we can work on that. I would come in, because I'm not too far out from the hospital, and I remember coming in once and seeing that there was a example poll. These are your IV infusions. This is what you're going to connect to what. You have your runners, you have these stopcocks. That way you're administering the appropriate medication without pushing any other medication in to the patient. And then you have, I remember you're given a box of stuff. I kind of remember it being kind of like Chopped, you know, the cooking show Chopped. You have a basket of ingredients and it's like, here, work with this. And so I'm like, we should get nasal cannula extension tubings and then just connect Lopez valves, which are 3-way valves. And then we can feed our patients via NG tube from behind the door. We don't have to go essentially inside. And so all these things were being created, and then we would have a poll with all these explanations and all these, I guess you say, examples. If a nurse needed, like, oh, I have to infuse this patient with this medication or whatnot, they would go see how they would be able to perform this duty without getting themselves exposed to COVID.
Right. And while remaining, keeping everything sterile and,
correct.
So
that was making sure that they weren't touching the floor.
Yeah.
How you can float them. How can you prevent the door from closing on a tube, right?
Yeah, we, trial and error. It was like real-time innovation happening. And it was actually a beautiful thing to witness and to be part of.
Yeah, I agree.
So I love the image, Carlos, of you on your day off searching social media. I think that this is a new way that we have crowdsourced our information and our innovation ideas. I'm curious, what search terms did you use to discover how to solve some of these problems around infection control, exposure, minimizing viral load? What do you search for?
Well, I'll tell you what I did. I have a lot of nursing pages that I follow on Instagram. And I feel like all the nurses who've been involved, everyone who's been involved with this pandemic, have used it as a platform to just upload and just kind of have a brief summary as to what they're doing and what they're posting. And so I didn't search guidelines. Instead, we spoke with the infectious disease personnel in our hospital to see if we can continue doing what we're doing. How can we improve and prevent any of the infection rate from going up by doing the extended tubings or by keeping the pumps outside and not inside the room? And so The point was to go in and out of the rooms as quickly as possible, but getting your work done as efficiently, right? And so you're trying to go into the room, connect the patient to the medication, run back out in hopes of not getting yourself sick, but also make sure the patient was receiving the adequate medication.
I mean, look, we all are used to working as a team. We're used to working in very stressful environments. This was like probably the most stressful environment we've ever worked in, but it's not like we were not used to working under pressure. Mm-hmm. So I think we took what we were used to doing and just like up the ante on it.
Especially one of the biggest things with having the pumps, the medication pumps outside of the room was the titration. In the ICU, you're trying to wean these patients off of pressors as quickly as possible in an effective way without causing any harm. And that would require you going in and out of the room countless times to drop pressors or increase the pressors or switch pressors. And the idea of having the pumps outside made it easier for us to do it in real time and be able to manage these patients as they're responding to these medications. If it wasn't for that, we would be delayed in helping a lot of these patients.
Right. It wasn't just for us. It wasn't just preserve PPE and exposure. It was really the best thing for the patients. They deserve to have the best possible nursing care, whether that be in a pandemic or on a regular day.
You also have the concern of sedation, medication for sedation to make sure they're ventilating appropriately. Mm-hmm. A lot of these patients who would abruptly just wake up, you're running the risk of them self-extubating and you have to run in there and try to help them out. You have a patient's life at stake. And so you want to make sure that you're taking every single precaution to do what's right for both the staff and for the patient.
And for the community.
For the community, exactly. Because you're coming back home and you could be carrying the virus, but you're not sure. And so you want to prevent that at any time. I have to give it off to my colleagues in Mount Sinai, but as well throughout the world, nursing staff and hospitals, everybody. Because if this information, essentially thank social media, because if it wasn't for that capability, I feel like we would all be lost.
Yeah, there was a lot of sharing, and it was sharing from the standpoint of a humanitarian effort that everybody is going to be facing this. Let me share what we've learned, no matter where it's being learned. And also pressors. When you're describing pressors, that's not something that people might be familiar with.
Right. So these patients are coming in very sick. A lot of them, if not most of them, are in septic shock. So they're not able to maintain their blood pressure because your system is going into shock and you're losing appropriate volume. And so the pressors help decrease the permeability. It also helps with the contractilities of the heart and vasculature to try to maintain your blood pressure. Now, you see this a lot in the ICUs because when you go into septic shock, you develop a fever. And so your organs don't respond appropriately. Your blood pressure tends to tank. And because your blood pressure is tanking, you can also affect your both cardiovascular and pulmonary systems. So these medications that we use help maintain the blood pressure of these patients at an appropriate level.
The half-life of these medications, meaning the time that they work, if you stop an infusion of that medication within seconds, they stop being active in the bloodstream and you'll lose a patient's blood pressure. So when Carlos is talking about the logistics of switching lines over, sometimes you only have a few seconds to switch one line to the new line before the patient's blood pressure starts tanking.
You'd have one nurse outside manning the pumps, when to stop the older pump and when to restart the new pump. And then you have one nurse inside the room. We would typically use like a little speaker that would allow us to have a communication between rooms or one room and outside of the room. And that was key. I remember I had patients who were on 3 vasopressors and one of them can be turned off for a fraction of time and it would completely throw their blood pressure off. And so that was crucial for us. That was extremely crucial for us to have that communication, say, all right, I'm turning this one off, we're restarting this one. And then you have that nurse inside the room cleaning the hub, connecting the tubing correctly, making sure it's infusing appropriately, it's not leaking, making sure the site was correct, and that the line was good. That was the important thing. Because again, a lot of times you are outside of the room, you can't see what's going inside the room. The patient can't tell you that something's hurting or whatnot. You have to be on top of that.
Yeah, there's a lot of coordination. And the other part that gets left out of the telling of this story is you all are in masks and goggles, and so you can't read lips. It's very hard to see somebody's eyes, and eyes are so expressive, like things aren't going so well, or yeah, I got this. So you've lost at least half of your communication. A lot of times in ICUs, we have doors open. So just the volume of being able to hear somebody's voice unmuffled has been dramatically changed. Yeah. So it's hard to tell this story with the level of detail and have people paint the picture in their minds to see it. The other part that you guys have had to innovate on is, so you've completely reconfigured this ICU setting, completely reimagined your teamwork, the equipment that you're using, and then the next added layer is you don't have any family members. You only have your staff, and you don't even have your full staff.
Yeah, not having family there. I mean, family is such a huge part of what we do in the ICU with these critically ill patients, especially when a patient is terminal and in the palliative stage of care. So that, I think, I mean, I'm speaking for myself, but I think that was one of the hardest things that we had to deal with. It's not the being hot and you can't hear anything and being in the rooms in the PPE and caring for the patients. The hardest thing, I think, was these people were dying alone and we were the last people to be with them. And, you know, you feel a huge responsibility to do the right thing, to be with the patient, to communicate effectively with the family. And we had to utilize some like alternate communication tools. I mean, our chaplains and our social workers had a huge role in that. In the beginning, they were working remotely. And then I remember our social worker, she said to me, I couldn't do it anymore. I needed to be in the hospital. I needed to physically be here. It was very hard for her to not be where we were, where it was all happening. So they started coming into the hospital. And, you know, they were in their PPE and they would help us coordinate the Zoom calls and the FaceTime calls, the video calls. And we have two wonderful assistant nurse managers who some days that they were just donning and doffing PPE, going from room to room to relay messages, last words. And it was pretty intense and heartbreaking. But yeah, we really had to utilize alternate forms of communication. Our interns and residents, they spent hours on the phone every day updating family members. Like every family member got an update at least once a day, so oftentimes twice a day from one of our residents. So it was really, yeah, I mean, I think we did an amazing job on that front. But it was a huge part of what we did during that time.
I've had my fair share of going in and being on a Zoom call with the family members as they're speaking to the patient, and I'm the one holding the patient's hand and touching the patient. You'd hope that it would bring some sort of comfort for them, right? They're not there alone. They're just not hearing voices of their loved ones. They're feeling that there's someone there with them. And that was very critical for me. It's the most difficult thing to do when you're caring for a patient and there's no family members around and you put yourself in their position. And you say, wow, I would not want to be alone in this situation. You're scared. You're scared. You don't know what to do. You don't know what your body's doing. And sometimes it's just comforting to have someone there with you. And that's exactly the mentality that we all came in with. And we're like, we have to be here for the patient. They can't feel like they are alone.
Yeah, Simone, I became aware of your work and your position in New York as an ICU nurse through a piece that you had written. And I don't know that you wrote it with the intention that it would be in the op-ed page of the New York Times.
No.
But it probably was therapy in some ways for you. Could you read some of that?
Yeah.
One of the parts where I'd love for you to start that I think really captures what Carlos is sharing this is, I guess, just after you've started your shift and you're getting ready to have a quick huddle.
We have a quick huddle to confer about patients. Who's the sickest, who's about to crash, whose family has been calling and needs an update. We assess what supplies are low. We don N95 masks. We wear them all day now. I don't have a specific patient assignment yet. I'm the float nurse doing a range of things. My first task is to help with post-mortem care on a COVID patient we just lost. We had watched her slowly die over the past few days. We did everything we could. It's just me and a nursing colleague in the room. It's a grim affair. We wrap the patient's body securely, stroking her brow and wishing her well on her next journey. My colleague removes her jewellery carefully. We know her daughter will want it. I have to collect her belongings because security isn't allowed to come into the room. It moves me to see her wallet, her planner, her toiletries. Only a week ago, she was a person with a future, with plans, with cherry-flavoured lip balm. Carlos was the colleague in that story, so it's quite fitting that we're both sitting here. Remember that, Carlos? It was
I remember it vividly.
Oh my goodness. I think that was the first COVID death that we had, or it was one of the first that I had. And setting the scene for you, it was so hot in that room.
Yeah.
We had our gowns on, we had our masks, our N95s, our shields, our whole thing. And going through her, we don't usually do that. We don't usually have to go through people's belongings. There's something so intimate about seeing people's personal effects like that. Her planner had writing in it for what she's doing next week. It was just it just hit us. And I just remember Carlos's face, and all I could see of his face was his eyes. And we were distraught, both of us. But we had a job to do. We just had to do it. And I'll never forget your face, Carlos, when we were in that room. I knew what you were thinking because I was thinking the same thing. And I'll never forget that. It was really this person. And if it weren't for this virus, she would be alive.
Yeah.
It's very difficult. It's difficult. It's difficult in itself when you are preparing a body. But during this pandemic, it's what more do we have to see? It's ridiculous. And that's what was going on in my head. I felt so bad for this patient because I saw her transition. I saw when she came in. I saw where she was heading. There was one time I had so much hope for her. And then I come back and I'm with Simone, and I remember just standing there trying to take it in. And it was so difficult. Like she said in her article, we do everything gently. I think one of the hardest things, though, is unfortunately these patients come in sometimes, they have their cell phones. This has happened to me multiple times where I'm preparing the body and I have to go through belongings. And the hardest thing to see is that their phone is still working and you have missed calls. And that just pushes me over. I have to stop at that point.
For those of us not in the ICUs, we see numbers and graphs. We see descriptors. You're seeing those lives, those families, and those people as individuals, as physical bodies, the families on the other end of the phone, the clothes that they wear, the type of work that they do, where they worked, who they were taking care of. I think you have a different story about those lives that the rest of us are seeing as numbers and graphs.
Yeah.
Sorry, go ahead.
I was just going to give a shout out to our colleague Valerie, who works with us, who she started, we had these makeshift doors when we made our negative pressure rooms, and they had clear plexiglass on each side. And one day she was talking to a patient's wife, and she asked, she wanted to find out some things about her patient. Like, normally we get that information just because family is around. We have opening visiting hours in our ICU. We want to encourage family involvement. So you hear little things about the patient, but we didn't have family around, so we didn't know anything about these patients. They were sedated, they were on a ventilator, we couldn't interact with them. So Valerie asked some questions about her patient, and she asked permission from the wife if she could write down some little bullet points about her patient. And the wife was like more than happy. She was actually thrilled to kind of humanize her husband for everybody. And then it became sort of standard for every patient. We would ask permission, of course, from the family. And as you can, I want everyone to know, we didn't have people coming in and out. It was just clinical staff. So it wasn't like people were walking in and seeing all this information, but we got permission, and we would write down little things about each patient.
Who their favorite sports team is, what music they like to listen to.
And he loves jazz, and he has 3 children. He's really excited about his grandchild that's going to be born in the fall, and just all these very humanizing things. And it was actually really difficult to see that, but it also really helped us because it humanized things for us. I mean, I don't know if people can appreciate, like, we're getting these patients from the emergency department, from other floors of the hospital, and they are already like they're only coming to us when they are critically ill. They are in a drug-induced coma. They are on a ventilator. There is no interaction with these patients. We're not speaking to each other. We talk to our patients, right, Carlos? Like, even if they're sedated, we still speak to them.
I believe they're always listening in.
Yeah, so we talk to our patients, but it's not the same channels of communication. So that was something that was like really important for us, just to help humanize patients through that, getting the information from the families and writing it, having that intimate knowledge of like what that person did for a living, like what they were passionate about. It made it harder in some ways, and it was an element that we really needed to have that was missing because we didn't have that family presence there during that time.
Had you guys always been leaders of innovation throughout the system?
Not officially, right? I feel like we were recognized in a way that we had never really been recognized before, and not through anyone's fault. It was just that our specific skill set was the most in demand during this virus. I mean, we are pulmonary ICU essentially. I mean, we do livers, we do kidneys, we do all the other organs, but we're a pulmonary, we work closely with the pulmonologists. We were uniquely qualified to lead the nursing care in this situation. So I think it really dawned on us at that time that if we're not going to be leading this, then who is? Like, we are the ones who have to be at the forefront of the innovation. But I think, in regular times, we sort of collaborate. All of our skill sets are equally needed.
We help each other out. Even though we are a teaching hospital, we're all learning from each other. We try to understand this as much as possible. And so we're getting these patients who seem like they're in severe ARDS.
Acute respiratory distress syndrome.
Yeah, exactly. So do we address this as a respiratory disease, infection? Like, what is our protocol on these patients now? And now you're receiving these patients, and your intervention list is, we're going to prone. We're going to get them ready for proning because it seems to be something that's working, and they're presenting with these ARDS-like symptoms. But again, I mean, going back, the doctors were even confused. They didn't even know what course of action this virus is going to take.
Having like specialized teams to do certain tasks was really helpful and freed us up a lot in terms of the general patient care. I would love to see more of that. It was really wonderful to work with specialties that we don't normally get to work with. During like the very intense weeks where we had peaked, we were working with nurses and physicians from all around the hospital from completely different specialties. Carlos, you probably remember the NICU attending that we had for a couple of weeks, he was amazing. We had like these surgeons who were like chief surgeon from our hospital who they came and they were like, what can I do? And they would say to us, the nursing staff, these are like surgeons at the top of their field, and they'll be like, we don't know what we're doing. This is completely not our specialty. Let us know like how we can help you. And they couldn't help us enough. And they were incredible. We had nurses from all over the country, travel nurses. We had nurses from the floors at Mount Sinai who came, and they couldn't help us enough.
Can you describe proning, what that is?
Yeah. So proning was actually invented by a nurse. Shouldn't be surprising to anybody that a nurse was the innovator of proning. I think she realized, or her observation was, when patients were turned over. Proning, people probably know, is when you're on your stomach, lying on your stomach. We had a name for it, adult tummy time was what we started calling it in the hospital. Mm-hmm. So when you're on your stomach, the upper parts of your lungs get more oxygen and more blood flow. You normally, lying on your back, and it's the front part of your lungs and the bottom part of your lungs that get more blood flow. So when she would notice when patients were turned on their stomach, their oxygen saturation would go up. And it was quite common, I think, in the 80s and 90s to prone patients. And then during the 2000s, we very rarely did it. But we learned from our colleagues in Italy and China that proning was one of the problems with COVID, the oxygenation, hypoxemia, numbers that we have never seen in our lives. We would see an oxygen saturation. Your oxygen saturation should be 95 to 100%. We would see an oxygen saturation of 20, which is barely even compatible with life. So we were seeing this profound hypoxemia, and we quickly learned from our colleagues abroad and from our own practice that when we would turn patients on their stomach, their oxygen saturation would improve immediately in most cases.
And that's without any changes in the ventilator settings or oxygen levels? Right.
You're just giving those parts of the lungs that aren't normally perfused, you're giving them a chance to take over. These patients have tubes coming out of everywhere, lines with all of those very critical medications going through them. So it would take 6 people to turn a patient from their back to their stomach.
All of whom are in protective equipment, completely gowned up. Yeah,
quite the choreographic display.
So prior to the pandemic, what was your role as innovators in the hospital? Or in the health system, really?
I mean, nurses innovate every day. Turning treatment plans into action uses a lot of innovation just to care for a critically ill patient. But I think that was just the expected level of innovation that we would do on a daily basis. It wasn't necessarily something that people were aware of. A lot of what nurses do is hidden. It's hidden away in the hospital, or, if you haven't been critically ill, or even ill in a hospital, you wouldn't know what nurses do. You watch TV, all you see is doctors, and nurses aren't really visible in the media. But during COVID, I felt like we were suddenly thrust into the spotlight. People wanted to know what we were doing, what we were seeing. It felt different during COVID. It felt like people were finally seeing us and wanted to know.
I think COVID gave your innovation skills a platform and a spotlight that had been maybe missing?
Yeah, 100. Yeah, absolutely. Yeah, we were always doing these things. I mean, we're always, every shift, every hour, trying to do better for our patients, do things in a more efficient way. I mean, Carlos has been hacking since probably, his career began, but suddenly those skills were needed. So yeah, we were always innovating. It just was, it was just not visible.
I just find it kind of funny how they stated that 2020 was going to be the year of the nurse. And
we were expecting something a little bit different, right?
Yeah. Yeah. And but as Simone was saying, I believe we were always there. But I think with COVID, now you get to see the healthcare system as a whole. Everyone has a very important role to play. And nursing has really stepped up. It's become a scene where both doctors and nurses are able to work together. There's not there's a such thing as a leadership and then everyone just follows through. It's become a cooperation amongst both fields. We're both in the medical field, but we both have different things to offer, and collectively we're working together. And I think that's the important thing.
Throughout the world, nurses have enjoyed the public's appreciation and trust. And now, during this shared global public health crisis, is an opportunity to go deeper into the critical and truly life and death details of what nurses actually do and how innovation unfolds. Working behind the doors of restricted areas of our hospitals, behind a mask, or in the privacy of a clinical interaction or the sensitivity of a sacred moment, the technical aspects of care, the policy choices, and the tough medical decisions are often, as Simone says, hidden. Nursing innovation often operates in stealth mode. COVID-19 has revealed, accelerated, and elevated the innovations that arise from the up-close and very personal, tender and sensitive moments, and also the brisk and efficient work that happens regularly in every care setting. As the pandemic intensifies, treating the human side of this disease with nursing innovation may be just the thing that we need most. For See You Now, I'm Shauna Butler. Thanks for listening.
Johnson & Johnson has always supported nurses as essential healthcare leaders and is proud to power up nurse-led innovation that is transforming health outcomes through skill building, leadership development, and more. The American Nurses Association ignites and celebrates nurse-led innovation to redefine quality nursing and advance healthcare for all. Johnson & Johnson and the American Nurses Foundation are proud to have launched the Coronavirus Response Fund for Nurses. Go to the American Nurses Foundation website to learn more, and thanks.